Good afternoon. My name is Allison Peisner, and I'm the manager of the Lupus and APS Center of Excellence at Hospital for Special Surgery. I'm excited to partner with the Department of Social Work in honor of Lupus Awareness Month and welcome you all to this important presentation. I would like to thank all of you for joining us this afternoon and for submitting your thoughtful questions and comments during registration. Today, I'm accompanied by my esteemed colleague, Priscilla Calvache, the Assistant Director for Lupus Programs and Community Engagement from the Department of Social Work Programs at Hospital for Special Surgery. The Department of Social Work Programs at HSS offers the most lupus support and education programs in the country. All of our programs are free and available in English, Spanish, and Chinese. For more information about our support programs, please view the link embedded in the chat box. Priscilla will join us later to facilitate the question and answer portion of the program. Before we get started, I'd like to begin with a few housekeeping rules. Participants will be muted during the presentation, but we are highly encouraging you to please use the chat icon to send questions throughout the presentation. Dr. Kiro and Dr. Callis will be taking your questions following the presentation. Lastly, I would like to introduce our program evaluation. Your feedback is important to us and helps us to inform future programs. We will be embedding the survey link in the chat box and kindly ask you to please complete our brief survey at the conclusion of today's program. At this time, it is my pleasure to introduce our speakers this afternoon. Dr. Callis is a physician scientist and rheumatologist in training at HSS with special interest in caring for patients with systemic lupus erythematosus. In addition to her current training as a rheumatology fellow, Dr. Callis completed 2 years of clinical and research training at the Johns Hopkins Lupus Center in Baltimore. Dr. Kiru is a physician scientist and rheumatologist specializing in the care of patients with systemic lupus erythematosus. He is the director of the lupus nephritis program at the Hospital for Special Surgery and the co-chief of HSS's lupus clinic. He is an associate professor of clinical medicine at Weill Cornell Medical College. Additionally, both Dr. Callis and Dr. Kiru serve as principal investigators for many clinical trials in lupus and lupus nephritis and are part of the Lupus Clinical Investigators Network of North America. I'm excited to turn it over to our speakers this afternoon. We will hear from Dr. Callis, followed by Dr. Kiru. Thank you.
Thank you, Allison, for this very kind introduction. I just want to make sure first that everyone is able to hear me and that you're seeing my screen.
Yes, you're good to go.
Okay, so good afternoon, everyone, and thank you for joining us. I'm glad to see such a huge turnout, and I hope you'll enjoy this overview of lupus treatment. As Allison mentioned in the first part, I will be discussing all the current available treatments for lupus. In the second part, Dr. Kiro will address a novel treatment that is being studied in lupus called CAR-T. There's a lot of information, and the purpose is not to memorize all the treatments that we're going to go over, but to share with you the excitement and the hope that we have for the treatment of lupus in the very near future. We will have enough time at the end to address your questions that you sent already or that you might have along the presentation. So please note them down. This is our disclosure slide. We just wanted to mention that Dr. Kiru serves as a principal investigator in many clinical trials in lupus and lupus nephritis, and he serves also on the advisory boards of many pharmaceutical companies. The information that we present here is intended only for educational purposes and not to be used as therapeutic advice. Therapeutic decisions should be closely made with your treating rheumatologist, as there is not one-fits-all therapy and the treatment should be individualized. Before I dive into the treatment of lupus, I would like to go over what is lupus. Lupus is a chronic autoimmune condition where your immune system, which is in charge of defending you against viruses and bacteria, starts by attacking itself. It's like when you have a dog that is supposed to protect you against the bad guys and it starts to bite you. In lupus, the attack can be on any organ in the body, like the brain, kidneys, joints, and the skin, among others. Every patient can present a little differently, which makes it difficult to diagnose. Lupus is more common in women than in men. 9 out of 10 patients with lupus are women. It tends to target individuals between the ages of 15 and 45. Women of colors are 4 times more likely to develop lupus. While there is no cure for lupus, there are medications that can help treat the disease. So how do we treat lupus? To answer this question, we need to understand what is the cause of lupus. What we know so far is that certain individuals are born with a genetic predisposition, and when they are exposed to certain stimuli, which can be an infection or a drug, it perpetuates the disease and causes the immune system to become overactive, producing antibodies against one's own organs. Lupus involves many parts of the immune system, as we can see in this graph. I want to highlight a few of them because they are important to understand how the medications for lupus work. We have the cytokines, which are proteins that ensure communication between the cells of our immune system. And we have B and T cells, which are specialized cells of our immune system. And when this autoimmune disease starts, and when our immune system is malfunctioning, it will lead to inflammation in many organs, as we already showed in the prior picture. Why do we treat lupus? We treat lupus to prevent organ damage that can result from ongoing inflammation. Lupus can cause kidney failure requiring dialysis and eventually transplant. It can cause disfiguring, scarring, and joint deformity. But most importantly, we treat lupus to improve the quality of life of the patient affected with this condition. Before I go over medications that are considered in the treatment of lupus, I wanted to go over very important components of the treatment other than medication. First, sun protection. Exposure to UV light can cause or worsen lupus symptoms, so it is important to stay in the shade as much as possible, invest in a hat with a large brim, and use good sunscreen. Second, quitting smoking. Cigarette smoking has been proven to worsen lupus, prevent medications from working, and increase damage in patients with lupus. Third, exercise. It can be very challenging to exercise when your lupus causes fatigue, joint pain, and other symptoms like breathing problems. But being inactive can cause you to lose muscle strength, which can make you feel worse on the long run. Even small amounts of gentle movements can be beneficial for your health. Diet and nutrition, a lot of you had questions about this. Most people with lupus do not require a special diet, but should instead eat a well-balanced diet that is one with low fat, high in fruits, vegetables, whole grains, and contains a moderate amount of proteins like meat, poultry, and fish. The last component that I wanted to discuss, yet a very important one, is vitamin D. Vitamin D was proven to help in controlling disease activity and reducing protein in the urine, which you probably know can indicate kidney involvement in lupus. Now, moving on to medications that are used in lupus. The most universal medication in lupus is, as you might know, hydroxychloroquine. Regardless of which organ is affected and the severity of the symptoms, every lupus patient should be on hydroxychloroquine, except those with allergies to the drug or those with problems in the retina. The benefit of hydroxychloroquine in lupus are broad and include relief of whole body symptoms such as fatigue, pain, and fever, as well as reduction in disease flare, organ damage. It is the only medication that was shown to improve survival in patients with lupus. It is important to note that while on this medication, regular visits to the ophthalmologists are extremely important to monitor for any deposition of the hydroxychloroquine in the retina. What is the medication that should be limited as much as possible in lupus? It's, of course, steroids. Steroids are wonderful and are the fastest medication to reduce inflammation. They are needed in huge doses, which are called pulses of steroids, when there is organ-threatening inflammation of the brain or the kidney. They are used in lower dosages, orally or as injections in the muscles, for milder symptoms like inflammation in the skin, joints, or fluid around the heart or the lung. But they should be used for the shortest duration at the lowest dose possible, considering all the potential side effects associated with their use, like increased risk of infection, weight gains, high blood pressure, thinning of the bone, among others. To reduce steroids use as much as possible, we resort to other safer medications. First, I will briefly go over older medication that we have been using for many, many years. You're probably familiar with these medications. We have used them for years and they have worked well, but they suppress the immune system as a whole and are not targeted to specific components of the immune system that are involved in lupus that we showed earlier. They also have some side effects, and patients should have regular blood work to monitor their blood counts, liver, and kidney function while they are receiving these medications. For example, methotrexate and azathioprine are used if the predominant symptoms are skin, joints, or pleurisy. Mycophenolate is the first choice for kidney lupus, but also used for other organ involvement like the skin. Cyclosporin and tacrolimus are from the same family of medications and are used in kidney lupus in combination with other medications, like mycophenolate, for example. For more severe disease, we use intravenous medication. Cyclophosphamide is a chemotherapy drug that is only used in very severe kidney and brain lupus. And the reason why we limit its use is because it has many side effects, like low blood counts, infections, early ovarian failure, and increased risk of cancer. Rituximab targets the B cell, and it was initially used in lymphoma. Since B cells are one of the malfunctioning cells in lupus, targeting them was found to be beneficial in the treatment of lupus. It has lesser side effects than cyclophosphamide and has the advantage of being given twice a year as an infusion. Despite all these available treatments, a lot of patients remain with active disease and on high doses of steroids. This need for new treatment options stimulated a lot of research to find new medications for lupus. In this part, I will discuss newly approved medications. 3 therapies approved for lupus in the last 70 years. This is definitely not enough, but a good progress. First, belimumab. The way that belimumab works is that it blocks a particle called BAFF that is needed for B cells to mature and be able to produce the antibodies that are eventually attacking one's organ. It was approved in 2011 for mild to moderate lupus and works well across many organ systems. It is generally well tolerated. It might slightly increase the risk of infection, and there are very few reports of depression and suicidal ideations with this drug. Anifrolumab is the second drug that we're going to discuss today. It blocks the receptor for type 1 interferon, which is another cytokine. And type 1 interferon is very important for the communication between the cells of our immune system. And it has been implicated as one of the causes of lupus. This medication was approved in 2021, so not too long ago, for moderate to severe lupus. It works very well on the skin and was published in many case reports to even work in patients who are refractory to many other medications. There is also an ongoing phase 3 trial to evaluate its role in lupus affecting the kidneys or lupus nephritis. It is important to mention that they noted in these studies that around 5 to 6% of patients on this medication had shingles or varicella zoster as a side effect, but all the cases were mild and treatable with a course of oral antiviral medication. The third medication that was approved recently for the treatment of lupus is called voclosporin. It is not really a new medication, but it was newly approved in 2021 for lupus affecting the kidney in combination with mycophenolate and steroids. It is from the same family of drugs that we mentioned earlier, if you remember, cyclosporin and tacrolimus. It acts mainly on the T cells of our immune system, and it has some advantages over the older medications in that the blood levels are more easily reached and do not need to be monitored. It is also an advantage because it is an oral medication. It is given twice daily. The side effect profile is very similar to the other medications that we discussed, and mostly consists of mild viral infection, urine infection, and shingles. So what is in the pipeline? Before I move on to the new medications that are being evaluated in lupus, I wanted to have a small overview about clinical trials. Clinical trials are carefully controlled studies that are meant to determine how effective and safe new treatments or a combination of treatments are in certain conditions. They are essential to find better ways of treating a disease. For a drug to be approved, it has to undergo multiple phases of development as seen in this figure. Phase 3 trials are the most important studies because they are the ones that will determine whether a medication will be approved for use in a specific disease. There are 71 ongoing therapeutic trials in different phases in lupus, which is very exciting because if some of these drugs are going to be approved, it will offer us so many treatment options. And before I handed over to Dr. Kiru, I wanted to include this table, which has the medications that are currently in phase 3 trials, which many of you actually inquired about when registering to this talk. I will not attempt to go over all of them, but I highlighted the ones that HSS is currently part of. And actually, we are enrolling patients for trials in these that are evaluating these different treatments. And with that, I thank you for your attention, and I will hand it over to Dr. Kiru.
Thank you, Romy, for the introduction and doing the background, so it makes my life easy. I would like to thank everyone that is joining us today here this evening, taking the time, and we hope that we can explain to you the new advances in the treatment of lupus. We're very excited. Thank you also to Priscilla and Alison for putting all the hard work to organize this event today in honor of the Lupus Awareness Month. So what is CAR T cell therapy? It's a very new treatment. It's also difficult to explain, but we'll do the best to explain it to you. So already Romy has explained about T cells and B cells. So T cells are lymphocytes of the adaptive immune system that recognize unique targets. We call them antigens on other cells. So they're very specific. So each cell knows how to target one target. Same thing with B cells. They're also very specific, targeting a specific target. So T cells can directly kill cells that are infected, for example, or malignant tumors. And B cells, by producing antibodies, can do the same thing, because antibodies can bind and then trigger other effects that will eventually eliminate the foreign organism or the tumor. Or in this case, when we try to manipulate the system so that it can target the autoimmune B cells that produce antibodies in lupus. So CAR stands for chimeric antigen receptor, chimeric because it's something that is made artificially from two different parts. It's a genetically engineered T cell receptor. So it uses something from the B cell product, the antibody. So that's the antigen recognizing part of the antibody. So that's very, very powerful to recognize the target that we need to apply it for. And then the second part is the T cell machinery that activates the T cell after it binds to the target. Next slide. So just to make it more clear here, so on the left side, you see the T cell here on the blue cell, and how it interacts with another cell on top, the red cell. So the T cell receptor has those two alpha and beta chains, and the antigen in this occasion is the red dot. So very tiny. So, but that's how the T cells work in real life. But we want to make something that can be more useful to us to target the tumor cell in this case, the malignancy. People use the CAR T cells. Until now, they have used it for malignancy, for example, for leukemias and lymphomas. And leukemias and lymphomas often are malignancies of the B cells. So the B cells can be autoimmune, like in lupus, but they can also be malignant, like a cancer. And in those cases, again, we need to target and destroy them. So we take the part of the antibody here. This is an antibody, it looks like a Y. We take the top part and we put it together. So this is the top part taken here. We put it together with the rest of the T cell receptor. So we took away this part out and we just included the part that is inside the cell. So this is the inside the cell part. So now this can bind to the target. And this, in this case, this is CD19 because B cells have something called CD19, is a protein really on the surface of the cell. And then when it binds, it activates the whole thing here. It goes to the nucleus, and then several products are produced that can cause inflammation and can also cause damage to the cell. It literally causes holes on the cell that is the target, and that causes the death of the tumor cell here in this situation. So that's the chimeric antigen. So that's the CAR that we genetically made. Next slide. So this is how the CAR T cell therapy goes. It goes in stages. So first, we have the patient who needs to do this. We remove the blood in order to get the T cells. So these are their own T cells. We take those T cells in the lab, and then we introduce with a lentivirus, which is a kind of a harmless virus that carries the gene we want to put. We put this gene to produce eventually this receptor, right? So we introduce this receptor that it shouldn't be there, but we make it happen. So we introduce it here, and now it's on the cell surface of the CAR T. So now it's ready to recognize the target. And then we grow this in the lab. And when it's ready, make sure it's safe to infuse. And then we infuse it to the patient, the same patient. So we took it from the same person, we give it back to the same person. And then what happens is this now immediately recognizes the target, in this case, the leukemia, and it kills the cancer. That's how it works. Let's go to the next slide. So anything you do has obviously good effects, which is the elimination of the bad tumor, but at the same time may have some side effects. So side effects that can happen in this situation is that when the T cell here, which is the cell that it has the CAR T, it gets it gets linked to the tumor cell and then gets activated. When it's activated, it produces many cytokines. That's what Dr. Kallas mentioned before. These are, for example, TNF, tumor necrosis factor, interferon gamma. So these cytokines are very powerful. They actually activate other cells like macrophages to produce more cytokines like interleukin-6 and interleukin-1. And those can produce fever and can also, if they're very high levels, they can cause also low blood pressure and so on. So if you have all these cytokines giving you fevers and inflammation, we call this cytokine release syndrome. And the cytokine release syndrome happens 1 to 14 days after the CAR T is infused in the patient's body. And it could be severe or very mild. In lupus, actually, it's very mild with a little fever or fatigue, but it can be severe in some occasions. So we treated with antihistamines, acetaminophen, which is, I guess, Tylenol, and then IL-6 inhibitors sometimes. Tocilizumab can be used to downregulate this inflammation. In some cases, the cytokines can actually go to the brain and can cause neurotoxicity, which means now you have side effects from the brain. People can feel confused, have a headache, or rarely get a seizure. And this happens usually after you have the first syndrome. The cytokine response is first, cytokine release syndrome first, and the immune effector cell associated neurotoxicity syndrome can happen a little bit later after that. And we treat this with steroids, and there are other experimental agents that people use to treat this. Next. So this slide comes from a recent review paper by Dr. George Seth, who is the pioneer from Germany doing this treatment in lupus patients. So in this review paper, they describe a case. It's a 32-year-old woman that has developed active lupus with kidney disease. We call this lupus nephritis, a very intense chest pain from pericarditis, inflammation around the heart, low blood counts, and anemia. She's positive for a characteristic test for lupus, which is the ANA test, the DNA test, and she has low levels of complement C3 and C4. And these all are indicators of high activity of lupus. Okay, she's getting treated with steroids, hydroxychloroquine, and mycophenolate mofetil. But unfortunately, the disease is not well controlled. She still doesn't get better. So the physicians then give her something stronger. We saw Dr. Callas's slide about cyclophosphamide, which is like a chemotherapy. And also they gave them belimumab, the new drug approved for lupus. And again, no improvement. So in this situation, the treating physicians decided to start CAR T therapy. So again, the same process. They took her blood. It's called apheresis. When you take the blood from somebody, that's called apheresis. You purify the cells, and then you introduce this very weak virus that introduces the gene for the CAR receptor. And now these are the CAR cells with a Y on the top, which is the receptor that will eventually recognize the CD19. Before we give it to the patient, we give a low-dose chemotherapy to kind of prepare the ground. We want to eliminate some of the lymphocytes that are already in the patient so that we can allow the new cells that go in to survive and do their job. And then we introduce with IV to the patient the CAR T. Again, these are coming from the same person. The patient needs to be hospitalized for usually 10 to 14 days in the hospital to watch them for any potential side effects, like we already mentioned before, the cytokine release syndrome and the neurotoxicity syndrome. This is what happened for this particular patient. So the CAR T cells, with the red circle here, interact with the B cells with the blue circle and kill them. So now if you see the graph down below, the first graph on the top shows with a blue line that the B cells went down to 0, and then they came back about 100 days later. It starts to come back. At the same time, the CAR T cells went up to a peak in about 8 to 10 days, and then they disappeared also, or they were very low levels. At the same time, the DNA antibody went down to 0. The protein from the kidney problem, the kidney was leaking protein because of the nephritis. The protein also went down by 3-4 months. And then the SLEDAI is something we use to monitor disease activity. It's a score we use, and also went down to 0. So everything got better. Patient was able to get rid of steroids and mycophenolate, belimumab, and all the other drugs they were taking. And those B cells that came back, they looked at them in the lab and they found out that these are good B cells. They're not the ones that produce antibodies. So somehow they were able to induce an immune reset, meaning the immune system now, at least for this time, became normal again without any autoimmunity. Next slide, please. Okay, so just to explain a little bit about how this happens, I have to tell you first a little bit about the B cells. So the B cells, remember, is the specific lymphocytes that produce antibodies, and they can be autoimmune in lupus. So they are getting produced in the bone marrow by a hemopoietic cell, we call them. The hemopoietic cells are cells that can go in different directions, and one direction is B cells or T cells, in this case a B cell. So the progenitor cell, the first cell is the pro-B, we call it. Then we have a pre-B cell. Then this becomes an immature B cell. And during this time, the body tries to eliminate cells that bind to self-antigens, self-targets. So most of the time, the body is successful, but sometimes it's not. So then some of the autoimmune cells can go into the circulation, and that's the circulation is the white space below. And those are the transitional B cells and then naive cells, naive B cells, which go to the lymph nodes, and then they can see targets, and then they can proliferate. They become memory cells or plasma cells. Plasma cells produce antibodies and go to the bone marrow again. Plasma cells can stay in the bone marrow for a long time, for years, actually, many years, and produce antibodies that are useful, for example, to target tetanus. If you get a vaccine against tetanus, you have plasma cells that keep producing the antibodies to protect you from an infection with tetanus. And some of those cells will produce plasmablast immediately without going into the lymph nodes. And this will be the situation usually with lupus. So these cells get rapidly activated and produce DNA antibodies and other autoantibodies. Okay, so now how can we tell which cell is which? We use these markers on the cell surface. So CD20 is the red marker, and it covers pre-B all the way down to the memory cell, but it doesn't cover plasma cells and plasmablasts. So CD20 is the target for rituximab, the Dr. Callas mentioned before. Rituximab is a monoclonal antibody which we infuse to patients, and when it goes in the body, it targets all the cells that have the CD20, and it kills them. Okay. So, but CD20 doesn't target well the plasmablast or the plasma cells. So some of these cells will be there, and they will continue to produce antibodies. So now, if we do the CD19 is the blue line. So the blue line now covers a larger gamut of cells, or even the pro-B cell. It goes all the way to the plasmablasts, but it still doesn't cover the plasma cell. Okay, so now if we do the CD19 with the CAR T, we eliminate now the plasmablast, and we eliminate more cells that we would do otherwise with rituximab. Okay, we still are left with the plasma cells, which are there. So, but their plasma cells, it looks like they're most of the time okay, meaning they are not the ones that will cause trouble. There are exceptions. They could be, though, some plasma cells that produce autoantibodies. And again, so that could be a limitation of the CAR T therapy, meaning that we can eliminate the immediately bad cells, but we may leave behind some of the cells that maybe in 10 years will cause something. So we don't know that answer to the question. Next slide, please. Okay, another busy slide, but I'll try to explain. Okay, so what happens on the left panel here is you have all kinds of cells. Some of them are autoreactive, the yellow. Some of them are memory, the dark blue. And plasma cells, plasmablasts are the light blue. and plasma cells is this other blue cell here, and naive cells is the green. The green, you can think of the green that these are the good cells that not autoimmune yet. So after we do the CAR T, everything goes away except for the plasma cells because they don't have the CD19. And then eventually the immune system reconstitutes with good cells, all the green cells here. And there's no yellow cells, which was the autoimmune B cells before. Okay, that's what we do, hopefully with the CAR T. And by doing that, we eliminate the DNA antibody because this is all produced by the plasmablast, which is eliminated. We eliminate the Smith antibody and other autoantibodies as well. But we don't eliminate things like measles, antibodies to measles, to shingles, or varicella. This is the useful antibodies that we have after vaccinations. And we don't eliminate some antibodies that might be important for lupus, like the Rho or Sjogren antibody, but that's a question mark. Maybe we do, maybe we don't. We don't know for sure. Okay. So now the difference between using CAR T for malignancy on the top is that there are many malignant cells. Like the tumor is classically composed of cells that are identical, and they just become many of them. So here you see many, many malignant cells. So if the T cells, the CAR T now try to kill them, they will get super activated. And if they become super activated because they have to do a lot of work, then they produce too many cytokines, and the cytokine release syndrome and the neurotoxicity will be very severe. However, in lupus, the autoimmune B cells are far less than in malignancy. So therefore, it's less likely that they will produce those syndromes. And that's actually the reality. Very few patients develop something. If they develop, a side effect is usually mild. Okay, so again, CAR T, CD19 CAR T cells can kill all the B cells, including autoimmune. Normal appearing B cells usually emerge after a few months, and we do not lose immunity to vaccines, so that's a good thing. And people with CAR T treatment, they are often able to stop all their lupus medications, even for a few years, from the preliminary results we have so far. So we still need more results, but preliminary, it seems to be very promising. So CAR T cells may be better than rituximab because they can go in the tissue, not only the blood. They can go within the lymph node, the spleen, and they can kill cells there as well. Again, still we don't know whether lupus can come back after several years, but it is possible, so we don't know that. Adverse effects we already mentioned, but they may be milder for lupus than malignancy. Next slide, please. Okay, this field has been rapidly evolving, and this comes also from the treatment of cancer, right? So it's been there, and now people try to adopt it in immunology and rheumatology. People use sometimes autologous. That's what we saw already, autologous cells taken from the body and given back to the body. Some people use cells from somebody else and infuse to somebody else. That's usually the case for natural killer cells. They can develop a way that you can store natural killer cells that have a CAR T there. They have a CD19 rather CAR receptor that you can use as needed to anybody. So that may be an advantage, but for the natural killer cells. But this is again something that we need to be explored further. So far, we know that the traditional way with the CD19 CAR T works best. And then people use stem cells sometimes to manipulate them to become CAR-bearing cells. People are also targeting, besides CD19, they want to target other targets. So for example, BCMA, which is a receptor in plasma cells. Remember, the plasma cells are not targeted by the CD19. Some people have done this as well. And in these situations, it works okay, but you need to vaccinate the patients again for everything they had vaccinated themselves before, because they lose all antibodies they had before, and they may need to be repleted with antibodies because they lose more immunoglobulins from this treatment. So again, every method may have plus and minuses. Okay, the next slide. Okay, so who may be an eligible patient for CAR T? So far, people have reached a consensus. This can change, but a group of experts thinks that we should do it for people that are over 18. They fulfill criteria for lupus by ACR and EULAR. They have to have antibodies to DNA or Smith, so they have to be definitely bad lupus, I guess. They have to have very active disease in at least one organ system, severe disease, or two organ systems a little bit less. So far, most of the companies prefer people who have lupus nephritis because, you know, kidney disease is one of the most serious manifestations of lupus, so they want to target somebody who has active and serious disease, and somebody who hasn't responded well to steroids, and at least two of the following treatments for at least 3 months of treatment. So for example, cyclophosphamide, like the case we saw earlier, mycophenolate, the belimumab, the azathioprine, or the anifrolumab, methotrexate, and so on. So all of these drugs, at least two of them for 3 months. If they didn't work, then maybe we have a chance to, maybe we should try this therapy as well. Contraindications, if the patient already has severe organ damage, they have kidney failure, they are on dialysis, for example, or they have heart failure, lung disease that is severe, malignancy, and tumor somewhere. If they have severe cytopenias or an infection that we cannot control, obviously they're not candidates for this treatment. Next slide, please. So again, take-home messages. This is a potentially promising treatment strategy for lupus and other autoimmune diseases. They actually try to do this for scleroderma, myositis, multiple sclerosis, myasthenia gravis, and other diseases. It may induce a long remission without need for medications. It requires, however, chemotherapy and hospitalization for at least 10 to 14 days. Potentially some life-threatening adverse effects can happen, although they are seen less often with autoimmune disease. And there may be unknown long-term adverse effects, which we cannot know at this point, from the persistence of genetically altered CAR T cells in the body. Probably this is not a major risk, it's a minor risk, but again, it's something that we need to see. Next slide. Okay, I want to thank you again, and just to remind you that here at HSS, we have a clinical trials program for patients with lupus and lupus nephritis, and myself, Dr. Fernandez, Dr. Callas are part. Emily, who is our research coordinator, and this is her contact information. We work together with New York Presbyterian and Memorial to do our work. Thank you very much.
Thank you so much, Dr. Kiru and Dr. Callas, for your comprehensive presentations. A lot of great information and promising information regarding CAR T-cell. At this time, we're going to transition over to the Q&A portion of the program. Just a reminder to please use the Q&A box or the chat box to submit your questions. I'm going to begin with some of the questions submitted by attendees during registration. We have grouped the questions that came in advance, and we're going to try to get to as many questions as we can before we wrap up this evening. But again, due to the overwhelming amount of questions submitted, we may not get to all your questions. So Dr. Kiru, we're going to start with our first question that came in advance is, how far away are we from CAR T becoming an accessible therapy for all lupus patients?
I think we're in the beginning only. So now we had only these first publications from Germany. Now the pharmaceutical companies are picking up. There are many of them, but still in very preliminary stage. This is phase 1, we call them. You saw phase 1 is the very early stage of development to a treatment. So it will take a few years to become available, and it will be probably, the same cost as in malignancy. I guess hopefully insurances will cover if it becomes FDA approved.
Great. Thank you so much, Dr. Kiru. And we had a question that came in when you were reviewing your case study on the 32-year-old patient. How long did it take to return to autoimmune? That was, I believe, specific to that case.
So that case was already having lupus for a few years. It got to the point that it was very severe. They treated, it never got better, and only with CAR T it got better. So it never got autoimmune again. I mean, that's the beauty, right? So 2 years later, the patient has no DNA antibody, no ANA antibody, the kidney got better, and they stopped the steroids and the mycophenolate and the belimumab, and they're still doing well. So again, this is something preliminary. We'll have to see, after a few more years what's going on. But so far, some patients are like that. So of course, I can tell that there are some cases that were not as successful. So from preliminary anecdotal reports, and that could be for several reasons, right? It could be that something happened and the manufacturing of the CAR T was not successful enough to be able to kill the B cells. It could have been that sometimes the lymphocytes were too little from the patient with lupus and then they couldn't make enough of them so there may be several reasons that people, as we get better, we will be able to improve on those aspects.
Great. Thank you, Dr. Kiru. Now, when we're thinking about CAR T cell, is it a single dose or does it need to be repeated cycles once it becomes approved?
Yeah, it should be a single cycle. Now, there are other companies, other, I guess, products. For example, the NK cells. Those they may be given several times to achieve the same effect. So again, we will see how this evolves. But for CAR T, the classic one, the one that I showed you, it's one cycle. That's it.
Great. Thank you so much. Dr. Callas, there was a question that also came in around how many active lupus trials were there and how many are in phase 3? I believe you said there were currently 70, but someone was asking about that earlier.
Yeah, so 71 lupus trials in different phases. In phase 1, there are 9 trials. In phase 2, there are 38. And in phase 3, there are 24 trials. HSS is part of 4 phase 3 trials right now.
Great. Thank you so much. Transitioning back to CAR T, someone's asking, how is it different from plasmapheresis and how permanent are the results of CAR T cell therapy?
Okay, plasmapheresis is a different process. It's again apheresis, right? So apheresis is the same word there, but apheresis now is for plasma. So meaning that we don't remove cells. We only remove the plasma, which means the fluid part without cells from the body. And we do that to remove antibodies. So the bad antibodies have to be removed so that the patient can get immediately better. We do that for very severe cases. For example, we do it for something called thrombocytopenic purpura, thrombotic thrombocytopenic purpura, TTP. We do that for alveolar hemorrhage. So that's a very bad complication in lupus. So that we want to do an immediate effect, take the antibodies out, but then at the same time, we want to treat the patients aggressively otherwise. So, and the plasmapheresis doesn't last. So meaning that the antibodies will come back unless you give more therapy. For the CAR T, things are different because we do it and it usually, if it's successful, right? If it's successful, which seems to be in most cases, the result will be long lasting for several months and years at this point.
Thank you. So just a follow-up to that, someone's asking, like, what happens if the CAR T cells begin to act badly? How do we turn them off or get them out?
Yeah, usually the CAR T will be eliminated or they will die off in the body after some time. And they, as you saw in the slide, they went up, they went higher, they multiplied in the beginning to do their job. As they were doing their job, they were activated and proliferated. But then by the 10th day, 15th day, they were completely down. Now, we cannot exclude that maybe 1 or 2 will remain in the circulation. Probably this will do nothing. But I guess theoretically, and I don't know how likely, this is very unlikely, that this could be a tumor, right? It could be a tumor that will be now a T-cell originated tumor that happens in the body. I think that would be a very rare situation.
Thank you. Do we have any information if this treatment would be approved for usage while pregnant or for those who are trying to become pregnant?
No, it's kind of not at this time. They don't allow that for pregnant people.
Okay, so no information yet for that. And another question around what are just some alternatives, if at all, to prednisone? Someone is mentioning in their specific case that it's still their primary treatment for their conditions going on, and they believe it's resulted in some avascular necrosis and osteoarthritis, as well as degenerative arthritis.
I think this is a very important question. We thrive always in our patients to decrease as much as possible and try to put them off prednisone. It's very challenging in certain cases, but this is the aim of the newer medications. What we are trying to do with these targeted medication is to spare patients the steroids and the side effects of steroids. So in clinical trials and in the studies that evaluated these treatments, they always check their steroid sparing effect. So how much are these medications helping us to take our patients off the prednisone? So the alternatives are to be discussed with the particular rheumatologist, and depending on the symptoms and the organ involvement, which there's a lot of considerations to be taken. But steroid sparing medications, like the ones that we discussed, including methotrexate, azathioprine, Cellcept, anifrolumab, belimumab, all of these are options and alternatives that should be started in order to decrease the prednisone and take the patient eventually off the prednisone.
Thank you, Dr. Callis. So we have some more great questions coming in about CAR T-cell and clinical trials. Who's qualified to take part in part of the trials?
Right, like we mentioned earlier, so this is something that it's an evolving field, but now they want to have people with definitely very active lupus that have all the autoantibodies, the DNA, the Smith. So they want to be sure somebody has real lupus and very active lupus. They prefer people with nephritis because that's an important, very important organ. If it fails, you get into dialysis or transplant. So you want to try to do the best you can. So that would be lupus nephritis that failed treatment with, let's say, chemotherapy or mycophenolate. So yeah, something that really, and then we want to, at this point, we want to avoid people who have already failed, meaning they're already on dialysis. So in these cases, when you have damage, we cannot reverse it, right? If it's something that is not reversible, unfortunately, we cannot do much with CAR T therapy either. And we want to avoid people who are high risk for infection. So we have to be careful to treat the right people, so for the maximal benefit and the less harm.
Thank you, Dr. Kira. We have a lot of other great questions that are coming in. Do CAR T-cell trials ever include overlap cases where it's unclear if the severe refractory organ involvement is from SLE and or other autoimmune diseases? In this specific patient's case, it's related to Sjogren's. Why or why not?
Yeah, so we already mentioned that the people they're starting to do scleroderma, right? Systemic sclerosis. They're doing myositis. I guess this is expanding. This is getting bigger. Multiple sclerosis. They do other diseases that are autoimmune. But the idea is that you want to treat a disease that is mediated, or the reason for the disease is an antibody. It's the B cell produces an antibody, and the antibody does the problem, causes the trouble. So because that's the whole problem. If we eliminate that B cell that produces this antibody, we can be hopeful to cause remission for the disease. If the disease is something that we don't know exactly what is the reason, what is the cause, then it becomes more difficult to be hopeful that this treatment will work. So we want to be careful who do we select. But yeah, this will be done on an individual basis. The physician who does the CAR T will evaluate the patient with an oncologist as a team, and they will decide who is the right person or not.
Great. Thank you, Dr. Kiro. Someone's asking or making a comment that some of the current trials recruiting are requiring a 28 to 30 day after treatment. You can just be 1 hour away from the trial site. What are they monitoring during that time, or is this out of an abundance of caution?
Yeah, I think, remember in the malignancy cases, they had more side effects. So we want to be careful. So if somebody gets, for example, fevers, the blood pressure drops, this is something potentially serious. They need to go in the hospital. They may need to be treated in the ICU until things get better. So, and then also the neurotoxicity, the headache, the confusion that can happen sometimes. These are things that they need to be addressed, quickly in the hospital to get better. Again, we're probably not going to see too many of them in autoimmune disease.
Great, thank you. Someone's asking about DHEA treatment. Is that a serious option? DHEA?
Yeah. So DHEA is a mild male hormone that is effective in treating some of the symptoms of mild to moderate lupus. Unfortunately, this is not a medication that is approved by the FDA for the treatment of lupus, but I believe the person who's asking this question might have read that it might have been studies or looked at, but not in clinical trials, for patients who experience hair loss, fatigue, cognitive dysfunction, like difficulty thinking, memory loss. But we currently do not use it in the treatment of lupus. It has been around for many years and kind of looked at in many small studies, but not really used. It is available as a dietary supplement, but it is not regulated. So we do not routinely prescribe it or use it in the treatment of lupus.
Thank you, Dr. Callis. And our final question for this evening is, are there any other natural alternatives to treat lupus besides medicines?
So you can talk, but I just wanted to mention that we have a trial actually for N-acetylcysteine, which is an antioxidant. So it's not a real immunosuppressive or steroid medication or anything. And by being an antioxidant can downregulate some of the activity of the immune system. So that could be something that is not a drug, but it can be helpful. It's available, actually. You can buy this medication, but we also have a trial here if somebody is interested. And then I guess Dr. Callas already mentioned being, eating a healthy diet. Vitamin D should be at the right level. Exercise, hydrate, avoid the sunlight. All of those things are very important.
Thank you, Dr. Kiro. And actually, we have one more question and we would have covered everything that's come in. Someone's asking about that case study that you shared again. For the medication that was used to treat the 32-year-old with lupus, if another patient had a history of seizure as a child, but no seizures for over 30 years, would they still be eligible for that type of therapy?
Yeah, so seizure is not necessarily a contraindication. And yeah, so as long as they take their medicines, if they are on medicines, that is okay. I don't think this is a problem.
Great. Thank you so much. We want to just give Dr. Kiro and Dr. Callis a warm thank you for spending this evening with us and really answering all of these great questions about this promising therapy for lupus patients.